Thank you for having me back. And we're running a bit behind, so I'm just going to go through some slides quite quickly. But I just want to make a point about the discussion we've just had, which is fascinating from mechanism, it's fascinating from clinical practice. But if you are a patient or an obesity physician, or a researcher for that matter, you will have noted that although we're still debating which operation is better, I have no doubt I'll be very happy to have any of those if I had diabetes. Very happy to undergo any of those. But the field of pharmacotherapy is moving on. It's moving on really fast, and we're missing that. We cannot talk in the same way we're talking about studies from 20 years ago and 30 years ago where the drugs didn't work. They're now working, and we need to take that into consideration. So I'll set a few perspectives on that, and I'll touch a bit on pharmacotherapy. And I will, these are my conflicts of interest, reflecting the fact that there's more than one approach to obesity care, and surgery is one of them, and is a key component, but in combination with other things. And I'll go through very quickly some thoughts, but these are pathways of metabolic regulation. Okay, if you think it's simple, it's really complicated. It's real. I haven't drawn this. It's a real pathways there. And what we do with different surgery is, even the ultimate combination operations we're talking about, is we're just attacking one target. But if we can combine some of those with some of the medications that are doing this, we can get better outcomes. And the point I want to make is, we all treat obesity as a disease, I hope, in this audience, but I just want to make a point about prevention not being treatment. For a very long time, the treatment options we used were actually prevention strategies, hoping for a therapeutic effect. So reduced food intake, lifestyle intervention work really well if you're trying not to put on weight. But if your BMI is 50, you're not going to lose weight by just lifestyle intervention. Or you may lose weight, but you will not get weight loss maintenance. So it's important we establish that. And in my view, it is the same as telling someone with lung cancer that they did not need a thoracoscopic resection with chemotherapy and perhaps immunotherapy. They just need to stop smoking and the cancer will melt away. It's a ludicrous thing to say. We don't do that, but very often it happens in obesity. And I think it's important we pass this message as people who do deal with obesity care in multidisciplinary teams out there. And we have to change the language, and I will say that if obesity is a disease, people are not obese, they have obesity, and therefore we need to be more precise about this. And it is important because it's not just about being nice and being kind to people, it is about changing the way we treat people. So if I say to you that I have a systolic of 200, do I have hypertension? Please raise your hand if you think I have hypertension. Most of you should raise your hands. Am I hypertensive? I think I am. Do you all agree? So if someone starts me on tablets and now my systolic is 120, am I hypertensive? No, I'm not actually. I'm not hypertensive. My systolic is 120, it's normal. But I have hypertension. And you can use other examples, the same with depression. If 10 years ago I was depressed, but I'm now on tablets, I still have depression, but I'm not depressed. So it's important to get that message right, because our patients who have obesity surgery, who undergo obesity surgery, the BMI of 65 we talked earlier on, they still have obesity. And even if we get them down to a BMI of 24, if you do the best possible operation, you start with a BMI of 40, the patient Andrew mentioned earlier on, when they have a BMI of 24, they still have obesity, but they may not be obese. And that's important to communicate that message. There is heterogeneity, and we talked about earlier on. There is a variable response to surgery. All of those operations that we talked about earlier on, they have different effects to different people. And if you get a really good effect with SADI or with one anastomosing or one Y, I'm going to say that again, you're not morally superior to the person who gets the worst outcome. You just have different physiology. And we need to consider all treatment options. And I always find it fascinating how a lot of patients go through treatment pathways. They get lifestyle intervention or pharmacotherapy. It hasn't worked for them, and we keep doing it. You would never do that in cancer care. If you give me chemotherapy that it doesn't work, the first thing you do when it stops working is you stop it, and you try something else. And if it's working well, but not well enough, you add something, and you escalate. And I'm going to show you some way of doing that. That's one way of doing it. So that's lifestyle intervention. Then you can do a professionally led lifestyle intervention. You get add medications. And I just want to make a point about that. Throughout the previous session, we talked a lot about the fact that the burden of medication usage is lower for some of the operations that have a bigger impact on diabetes. I find this, and I'm going to be provocative about this, I find this quite challenging to accept. Because all of us who do bariatric surgery, the first thing we do is start medications. Is there anyone here who does not give multivitamin tablets to their patients? Please raise your hand. We all do. So as people who start medications, why are you so obsessed about trying to stop the medications after diabetes? What's wrong with giving people metformin? And I can tell you for a long time, trying to make a point that this type of surgery is valuable, we've made the point of cost effectiveness. And I think we need to move away from that. It's the most cost effective intervention out there. We know that. When we talk about lung transplant or any kind of transplant surgery, when we talk about cancer surgery, we don't talk about cost effectiveness all the time. There's nothing wrong about patients being on metformin after surgery. Metformin is good, it's cheap, it's cheerful, it's safe, and it may save lives. So we need to change that paradigm. So adding pharmacotherapy on top of interventions is fine. Doing surgery, of course, is a gold standard. And adding medications on top of that is also okay. It's not failure. And again, I just want to make a plea to all of you. When we have patients with weight regain, that's not failure. Because, and I'll challenge you on that, for any of you who do cancer surgery, when we get a cancer recurrence, do you ever talk about failure of surgery? We just say that, we shake our heads, we get upset, we show compassion, and we often say that it's bad disease. We do not do this for obesity. We never blame the patient, we never blame the surgery in all other diseases. We need to do the same for obesity. It's not different, it's just like any other disease. So I'm just going to say a few thoughts here on comparing operations. So this is a study, again, we did a long time ago in Taunton, and I'll show you this slide earlier on. We looked at banding and gastric bypass. And although diabetes remission is different, I can tell you that A1C was exactly the same between the two groups. The patients were matched. So I have no problem with patients. I know earlier on, I know children had a very difficult job defending the ban, but for a very high-risk patient, and I see them, the patients who are 70 or who have a lot of comorbidity, diabetic food, they're waiting for an MRI to happen. You really don't want to do a gastric bypass, or they don't want a gastric bypass. I have no problem doing a gastric ban on them and also give them state-of-the-art follow-up and state-of-the-art pharmacotherapy. If you add liraglutide, and there's a randomized clinical trial happening starting in London, but in other places, and I randomize patients to this study where patients get a gastric ban and they get randomized to liraglutide versus placebo for 6 months. And we do see good outcomes. We often see good outcomes with the placebo as well. There hasn't been unblinded yet. It can work. There's nothing wrong about combining surgery with medications. And if you look at remission, when you do define it with strict criteria, this is what remission is. It's different to Roy Taylor's work that Richard Wellman talked about earlier on. This is really strict criteria what remission is. When we looked at our data, this is our data from 3 centers from Taunton in the southwest, Imperial College London, and Norway, and actually hospital in Norway. We looked at our remission. If you look at the meta-analysis that Chiton showed earlier on from 2004, the remission rate was reported as 85% and 90%. When we looked at our results, it was 60%, reflecting the fact that our patients are sicker in the NHS. But when you look at the newly defined remission, strict criteria, it goes down to 40%. If you don't put it less, that's 1 or 2 year follow-up. If you put half of your patients into remission, or actually fewer than that, you can't really say you have a major impact on diabetes. But when we looked at glycemic control, look at, and that's not a comparative study, it was not powered to detect that, but look at gastric band. Again, and I think sleeve gastrectomy, we think that bypass is better. I agree with Kamal. If you do systematic reviews, if you follow them up for long enough, you may find the difference. But if you move beyond remission and you look at A1C, you will not find big differences. It's about the same. Even if you do find a difference, you may have a marginal difference between bypass and sleeve gastrectomy. You may get a better outcome in the long term. That A1C is safe. That saves lives. If you take someone with an A1C of 8 and 7.5, you get them down a point down, you're saving lives. And that's what we need to focus on, rather than trying to find out which operation gives the marginally better remission. If you look at this study, this is Giulio Migroni's study with Francesco Rubino. randomized medical therapy versus bypass versus biliary diversion, of course you get a better outcome with bypass and biliary diversion. And that's 2-year outcome. But if you look at 5-year outcome, this is data from Phil Shower's unit in the Cleveland Clinic, where he was at the time. If you look at short term, that's 2 years, long term is 5 years. So I will just focus on the left-hand part of the graphs. All operations together, he gets a 43% remission. At 2 years, it goes down to 24 in the long term, and the recurrence is 19%. So you're putting 1 in 4 patients in remission, and 1 in 5 patients with care. You cannot say that we're curing diabetes by no stretch of imagination. You cannot say that metabolic surgery is amazing. If you look at these figures, with their in mind, and I'll go back to what Antonio said about cancer surgery, these are the figures we used to get for gastric cancer before the era of chemotherapy and radiotherapy. That's what we used to get. We can do better than that. And in the same way that we don't do randomized clinical trials between chemotherapy versus surgery, we now do, for esophageal cancer, we now randomize patients to surgery, chemotherapy, and radiotherapy versus chemotherapy and surgery alone. We need to include pharmacotherapy as part of our studies. We need to stop being afraid of using drugs for that. And I'll just show you some data on that. This is a now classic study. This is STENO2 from Denmark, from the Steno Diabetes unit in Copenhagen. So all they did was, there's no surgery arm here. They just take patients with diabetes. They gave them conventional therapy versus intensive therapy. Intensive therapy was giving them cheap drugs. Okay, it was ACE inhibitors, aspirins, and statins, and they saved lives. So all you need to do is just do some intensive, give some drugs, and you'll save lives. And if I was a doctor of any sort or a clinician, if I was a patient, I'd like to be at the blue line. You can save lives by doing that. And just look a little bit at what we do. So I'm going to take you back to the Trudy Migroni study. So this is a randomized clinical trial, published in the Lancet, 5-year data, by some of the pioneers in this field. And the remission rate, and they did biliopancreatic diversion, which we did not discuss today. Most of us would agree that's the Rolls Royce of surgery when it comes to diabetes remission. It has almost a mechanical effect. People do get better. If you look at 5-year data, they did not put a single patient in remission. 0. But they saved lives. They reduced cardiovascular risk, and they demonstrated that. And that's the point Carlo and myself trying to make in that editorial. If you combine those, you could get good outcomes for our patients. And looking at the medications usage, you can see that the medical treatment, of course, the bypass and the biliary diversion, we're using fewer drugs. And if you look at the STAMPEDE, and I haven't dissected the STAMPEDE study in this presentation, because I know it was mentioned earlier on, discussed earlier on. But you do have difference in medications between the groups. You could get better glycemic control by just accepting medication usage. And there's nothing wrong with that. So how can we combine, some thoughts on how we can combine that? How can we do that? First of all, we do know that the metabolic benefits of surgery do fatigue with time. And I know Kamal has done a lot of those systematic reviews. It's pretty clear cut. The outcomes are not the same at year 1 as they are year 5, year 10, year 20. We do know that revisional surgery is high risk. It's possible, but it's high risk. And it has a high cost, and high cost of complications. We do not use medications a lot. We do know that surgery has this profound effect in the first year or two. You control the disease, and you can use medications to maintain that remission, if you like. And remission can be defined differently, or control of this disease. So what can we use them? Preoperative weight reduction. So that BMI of 65, what's wrong about them having glucosidase? So you can have a lower, if you're worried about the perioperative risk, and again, it's not the BMI, they may have central obesity, they may be technically challenging, they may have a lot of comorbidity, you're worried about it. What's wrong about starting them with some pharmacotherapy for a year or two to get them lower down? Weight regain, and Jack talked earlier on about racial studies, which I'm extremely a big fan of. Take people who haven't responded that well, and then you can be a bit more elegant about it and find out who responds well, what's happening to the GLP-1, what's happening to the ghrelin, what's happening to other markers, and add targeted pharmacotherapy or blanket pharmacotherapy. Treat patients that have, and I would say this in a cancer context, I call this rescue pharmacotherapy. It's the same way you deal with disease recurrence when you have cancer, for example. And then finally, the one aspect of care that we never talk about is this adjuvant pharmacotherapy. Why don't we start this from straight away? Why don't we just maximize the benefit by giving them metformin, which is the easiest thing to do. Why do we have to stop metformin in patients after surgery? Why can we continue that and continue the statins? Big discussion about, do you stop the statins? Do you continue? Statins are good, they are safe, they are cheap and cheerful, and they may save lives. They may have a big impact in our survival benefit in the long term. And you can combine that, and as I've said earlier on, we do see that. Even you can do a gastric banding combined with pharmacotherapy for the really high-risk patients you don't want to do other surgery. Or you can enhance some of the operations that do not have the same effect. Sleeve gastrectomy, for example, you could add more into that rather than having to do the more complex surgery if you cannot do that. So I'm just going to go through some medications here. The two approaches. You can use anti-diabetic medications, GLP-1 analogs, SGLT2s, and you can use anti-obesity medications. So these are two broad categories, and it's lorcaserin, naltrexone, ibuprofen, phentermine, and topiramate, and they act centrally. And there is a review article in Obesity Surgery is going to appear in the next few weeks, where we summarize some of this. And this is what you expect. So liraglutide and semaglutide, GLP-1 analogs, more than 10% weight loss. That's about 1/3 of the patients. But if you are a super responder to that, you do see surgical levels of weight loss. I appreciate that's a small number of patients, but if you can give me an injection and I can have 25% weight loss maintenance, I'll prefer that to any of the operations that I mentioned earlier on. And if I can do that with an injection once a day, and even better, once a week, I'll prefer that. I appreciate that may be a small number, not everyone gets it, but also remember that not every patient gets a fantastic outcome after any of our operations, and some of them get complications from them. And then you have the other groups. Well, the next three are centrally acting, and of course you have SGLT2, and you can see the variable response. We used to talk about more than 5% weight loss, 10% weight loss. Remember, that's not excess weight loss; that's total body weight loss. You do get that in a number of patients, and the important thing to do that is to stop them when they don't work. If your patient is not a responder, stop it. And if your patient is a super responder, consider what you want to do in the long term. I don't think this is going to stop us doing bariatric surgery. I think we'll have patients who have a good outcome, the BMI of 65, they had a good outcome, they lost 25% of the weight, but they still want to lose more. And we can combine surgery with that. So what the future looks like, I'll just put a few more thoughts because I know we're really short with time. These are models of intermediate treatment between surgery and pharmacotherapy. Early disease, the BMI of 31, with high risk of diabetes, in the same way we do for endoscopic therapy of precancerous conditions like Barrett's esophagus, early treatment, bridge treatment for high-risk patients that I mentioned earlier on, and finally something that we rarely talk about, palliation for end-stage disease. Patients who are really high risk, they are not fit for a stapling operation or for any operation. What can we do for them? And the numbers are not small. What we do in most multidisciplinary teams in the UK is we discharge these patients. So the numbers are not small. This is data from North Bristol, and we looked at over 1,000 of our referrals, 1,200 referrals, and we followed up for long enough to see that half of our patients did not undergo any surgery or any endoscopic treatment. That is mostly because they didn't want it, or they were considered too high risk, or the MDT felt that was not appropriate. That's a lot of patients. And remember, the amount of surgery we do in the whole of the UK is about 6,000. There's a lot of patients out there who are not getting any treatment. And I think it's our role to try to change that. So I'll conclude by saying that there's no doubt weight-loss surgery is effective and safe in the long term, but we can do multimodal care to get better outcomes. We need to be more precise about it, both in pharmacotherapy and surgery, to treat this disease better. Thank you very much for your attention.